Hello, everyone. This is Chadi Alraies from SCAI-TV. With me is Dr. Yader Sandoval. He is interventional cardiologist from Mayo Clinic, and he gave a phenomenal talk about ultra low contrast case. And as we know, there's a shortage of national shortage of contrast. So we're gonna learn from him some techniques how to save contrast in this time. Yader, always nice to see you.
Hi, Chadi. Thanks for having me.
So can you go over some techniques that you presented as well as you learned recently about the low contrast use?
Yeah, no, absolutely. Well, I mean, seems like there's so many lessons from the pandemic, right? And this is the latest challenge, right? That we've had. Many places are dealing with emergent contrast needs, and I think, I mean, just many sites are dealing with this. And I think, fortunately, to some degree, I mean, in recent years, there's just been a lot of experience from ultra low dose contrast to even zero contrast, PCI. There's a lot of protocols as to how to do also very low contrast diagnostic angiography. So there's just a lot of lessons that we can implement from that. I can tell you, at least to start the discussion, that for the purpose of diagnostic coronary angiography, at least when I think about it, I think about either Paul Thurston and his group had put a number of years ago a nice protocol for diagnostic coronary angiography that really entailed using, really broad use of biplane coronary angiography, using 3 cc syringes, sometimes dilute the contrast, if need to even increase your radiation so you get high quality images. And really, if you use these things in a systematic approach, how you can essentially do coronary angiography, often with less than 15 cc's of dye on a routine basis. And if you do that, I mean, like, really you can save a lot of contrast. So again, really liberal use of biplane coronary angiography would be a CSC essential. And whenever there are lesions that are intermediate, or really any lesion that you're in the fence, I think probably liberal use of both coronary physiology and or intracoronary imaging IVUS to really make the sessions. And I think these approaches are becoming more and more helpful, particularly during this time if needed.
Yeah. So what is the definition, or what when they say ultra low dose contrast?
Yeah.
What is the definition of that?
Yeah, people use there are different definitions, but often one that many of us use, it's essentially GFR less than 1 ratio compared to GFR. So if the GFR is 30 cc's, you want to use 30 cc's of dye. So 1 to your GFR. That's a very practical, simple approach. There's other calculations, but that 1 to 1, I think, is just easy to memorize. For ultra low dose contrast, I think, there's this whole thing, and actually this is something that we've discussed at this session and a number of sessions. Actually, there's been a lot of interest at SCAI 2022, I feel, surrounding contrast issues and also contrast associated or induced nephropathy, is, I think, distinguishing what we're talking about. So the nomenclature has evolved now that it's contrast associated AKI. That's probably most of what we see. And yes, there is a small subset of patients that will have contrast-induced AKI. It's hard to distinguish them because, our patients have a lot of confounding factors. They have heart failure. They have, of course, CKD. There's hemodynamic instability. So trying to distinguish what's the true mechanisms, it's hard. And that's the reason many people have claimed that maybe we should be talking more about contrast-associated AKI. Irrespective of that, I think there's a lot of data, and Syed Ali and his group had a recent paper in JACC addressing outcomes. And the patients that do the worst are the patients that have CKD, that develop contrast-associated AKI, as compared to those that have no CKD compared to those that don't have contrast-associated AKI. So I think the message is that at least in the patients at the highest risk, so those that have advanced chronic kidney disease, it's probably not unreasonable to be judicious about contrast. So if you think about using at least less than 1 to 1 of ratio with your GFR, you can, again, the key, at least when I think about the steps, is you want to use that old angiogram as a roadmap. So you don't have to redo your angiogram. You have the roadmap. You put it right there in front of you. That's number one. Number two is, I would say, you want to recreate what they call the metallic silhouette or the coronary anatomy silhouette. So essentially, let's say you're dealing with an LAD with some diagonals. You have the old roadmap. So essentially, you wire the diagonals, you wire the LAD, and you use essentially all these wires to guide where you're going to balloon, where you're going to intervene, and that reduces the amount of contrast that you need. And then I would say there's two approaches to this. There are some people, and I've done this I'm doing more and more in in my cases, is also to understand whether I have obtained a satisfactory result, often just working over a corner physiology wire. So if I know what's the IFR up front, for example, I do my intervention, and then with a post-PSA IFR, I know, okay, I did a reasonably good job. And then also afterwards, I also liberal use of imaging. So I will IVUS, see what the vessel size is, balloon based on that, stent with IVUS, again, check apposition, expansion, dissection. So if you use both physiology and imaging, you essentially can do most of the procedure with very limited contrast. So I think that's how you can do ultra-low contrast. There are some sites and some operators in the country that are doing a zero contrast PCI. I would say that's less frequent, but if you're going to do that, for people that are very experienced with all these approaches, it's important to underscore that they often mandatory will always do an echocardiogram following the procedure to ensure that there's no effusion or tamponade, because that's the one thing that you cannot exclude in that approach. What we have done in our experience, it's more of an ultra-low dose contrast approach in which we do the intervention, and pretty much at the end we do a biplane picture and make sure that things are fine.
Well, this is a nice, very nice summary, practical summary for how to use a contrast and a very low contrast in these cases. So just to summarize, biplane, 3cc syringe, mixing if possible. And I think the most important thing is IFR or physiology and imaging utilization before and after, and the wire silhouette eventually. Yeah.
Absolutely.
Yader, thank you so much for the summary. Please watch these videos and others on SCAI-TV. This is Chadi Alraies from SCAI-22 in Atlanta. Thank you so much.
Thank you. I think I passed.
You did amazing.
All right.
You did an amazing job.
Thank you, Chad.